All right, for CAT 3, you're going to start with prone leg length analysis. So, what? Go ahead and bring your legs out, push out. And 1, 2, 3. Okay, and then I'm going to bring them in. I'm going to check for the superior medial malleolus. We'll say it's left leg, so it's left short leg. So then for glute fiber analysis, I'm going to come into the PSIS. And these points all they're indicative of the lumbar spine and the side spinous deviation. So L5 is at the PSIS, and then I'm going to go up the iliac crest. The more lateral we go, the more it goes up the spine. So it's L5 and L4, 3, 2, L1. And then Soto is it's indicator. Indicator is sciatica, and we said okay. So then it's both diagnostic and therapeutic, and so I'm supposed to be seated but on a chair, and then going to support the leg anteriorly, and I'm going to abduct the leg about 14 inches or so, and I'm going to hold and externally rotate and hold for 10-15 seconds, and then bring it in, wait 2 minutes, and then repeat. And then I'm going to ask the patient if it got better, worse, or stayed the same. And if it got better, then it is indicative of sciatica and piriformis. Then if it got worse, it is a sequestered disc, and if it didn't change, then it is a herniated disc. Now blocking for CAT 3. This is what I screwed up. I didn't ratchet on my practical. Okay, that pissed me off. Okay, so I would have the board 4 inches above the iliac crest, and then and sternal roll. Okay, and then it's a left short leg. So the block will be, it's passive blocking, and so it'll be at the greater trochanter, it'll be inferior and oblique, and then on the long leg side, it'll be at the ASIS, inferior oblique as well. CAT 3 blocking is to reduce pain and maximum of 30 minutes. And I would check after 3 inhalation or 3 respirations. If it's not changing anything, I'll have to ask you like it's a question. I can ratchet down to where it's like a CAT 1, and then if that doesn't work, then I will put the block back, and then go to the other side and ratchet down until it gets better. Okay, so then posterior iliofemoral ligament. I'll come in, I will check internal rotation both, and I will go to the side that is more restricted. I will find the greater trochanter, and I will go up an inch, or superior an inch and posterior an inch. I will do a double thumb toggle through the opposite, or my drive will be through the opposite obturator foramen. And then next would be, and I need to move the block if it is on that side.
I'm afraid to do it.
Then lumbar vertebral derotation. I go to this, for this I'll have the patient traction the head of the table, and then I will go to the side that is indicative from the glute fiber analysis. And that lumbar vertebra should also correlate to the cervical indicator. I will flex the knee, and I will, for derotation, I will go to the specified vertebra, and I will contact the spinous, the lateral side of the spinous, and I will push from lateral to medial. And then for, what is it called? The lumbar inferiority lift, I'll do the same there. The patient traction at the table, the fiber analysis will correlate to a certain vertebra. That vertebra will correlate, or will be indicative of or it'll match up with the cervical indicator. And I will contact the mammillary while I'm flexing the knee, and my line of drive will be I to S. Because I just dropped your leg. Acetabular goading, I will flex the knee. I will go to the greater trochanter and then to the acetabulum, and I will press until I find nodules, and then I will press on the nodule while I do little baby circles until the nodule releases and is better. Then orthopedic blocking, I will. Okay, for orthopedic blocking, for the side of spinous rotation, I will go to that side and I will remove the block in order for it to, and this will cause the spinous to derotate. So then put that back. And then sciatic traction, block CAT 3, the indicator is sciatica, and I will grasp the leg and I will traction for 5 to 10 seconds? Yes, 5 to 10 seconds, and I will repeat until there's no more pain or there's no more improvement. Then post-blocking sacral cup, we'll remove the blocks. Boom. Okay, so I will have the patient lift the leg, and I'll push down while they resist. Okay, and then I will check. I will press between S1, S2, and repeat. Okay, and then S3, S4, and repeat. And whichever one goes stronger, I will do double thumb toggle in either S1, between S1, S2, or between S3, S4, or I will press until noises, and then I'll retest. Sitting disc technique. Can you sit up, please? Not. Come here. Okay. I've had the patient sitting on the blocking board, and then I will go to the indicated spinous and I will push. I'll have the patient tuck their chin to their chest, and then inhale as they flex forward, and I am pressing I to S on the spinous, indicated spinus, and then as they extend, or as they come back up, I will press P to A and have them exhale. And I will go have them flex forward again, inhale, as I press I to S, okay, and I will repeat all 3 steps until better. And side posture. I'll say that you have the sciatica, and you have the sciatic leg down, so right leg, so she has a right leg, sciatica, so right side down. I'll put her in side posture, and then it's, if it's spinous rotation, or if it's rotation, then the spinous is pointed down, and if it's inferior, then the TVP is up. So then I will, if it's, I will be contacting mammillary, and the for the inferior, the line of drive is I to S, and for the rotation, it is P to A. And that is all. Take a minute.
You said I roll so many times.